Clinic, Omni Hospital, and a member of faculty in Psychiatric Division, Faculty of Medicine, Kurinda Wakana Christian University. He is a member of Section Psychiatry in Education, World Psychiatric Association, WPA. He was a member of International Advisory Board of World Congress of Psychosomatic Medicine, August 2015 in Glasgow. Dr. Andrew is a writer in national newspaper, a blogger, a public speaker, media best friend, and also a fan of social media. He has 3 non-fiction books and has publications related to psychosomatic medicine, psychiatry, and mental health. The first paper is entitled Somatic Complaints in Depression and Anxiety Disorder Patient. Dr. Andrew, please.
Thank you very much, Professor Sugahara. Ladies and gentlemen, it was a pleasure to come to this lovely meeting and would like to present about the somatic complaints in depressions and anxiety disorder patients. As we know that depressions and anxiety is increasing in the global populations now, and the number of people with depressions and anxiety is increasing from 1990 by 460 million to 650 million in 2013, and it was close to the 10% of the world's populations is affected with this kind of mental disorders. And if we talk about depressions, that the fact is a very common mental disorders. It is estimated by WHO in 2020, it will become the second global burden of public health in the world. And we say that the more women are affected by depression than men, and it's worse, depressions can lead to suicide. But fortunately, this is an effective treatment for depressions, and we know that we struggle for that, and in our clinical practice, we give the patients treatments related to depressions, and also how to maintain the preventions of relapse and maintain the remissions of the patient. We talk about the economic problems related to depressions, and it was said that every dollars invested in scaling up treatment for depressions and anxiety leads to returns of $4 in better health and ability to work. But the problem is, in our clinical practice, I am a psychiatrist. We know that the symptoms of depressions, most of us rely on the psychological symptoms, like sadness, loss of interest, overwhelming sad, anxiety, or excessive or inappropriate guilt. But sometimes we forget that there is also a physical symptoms, such as headache, pains, fatigue, or even related to weight gain or loss gain. So these kind of things that we in our clinical practice often forget about how to get the ideas to talk to the patients and ask specific questions about the physical symptoms, not only the emotional symptoms of depression. WHO in one of the report conducted in one of the journal in 1919 said that the 2/3 of the patients presented their depressive mood with somatic symptoms exclusively. So the people come to the physician, the primary physicians or the specialists with the symptoms of somatic problems, but the basics of the somatic problems is conclusively as a depression. And more than half complain of multiple medically unexplained somatic complaint or somatic symptoms. From this report, we know that symptoms of depressed patients attending primary care physicians come to the 96% of physical symptoms are reported. And it's very common to say that in the primary care, the complaint of the patients is back pain, neck tension, headache, neuralgia, even the specific like palpitations, stomach problems, dizziness, and drowsiness. And it was sometimes mixed up with other specialists, like specialists in internal medicine and also neurologists, when the patients come with these specific symptoms. I believe that most of the patients will not come to the psychiatrist in the first hand, but will come to the physicians in primary care or even the internal medicine, as specialists in neurologies or in internal medicines. And in this slide also, it was said that the chest pain, fatigue, dizziness, headache is one of the problems that related to the somatic symptoms of depression. And it was said that an organic cause of pain was found in only 60% of cases. So the other causes is unknown or medically unexplained, we said in the past. Many patients with depressive symptoms related to the chronic painful symptoms are very high prevalence in the subject of depressive symptom patients. The problem with the chronic painful symptoms, not only just one symptoms, but also more than one. And it was said that when we talk about the problems related to the symptoms of pain and also related to the problems more than two pains in the depression, the remissions may be affected. So the improvement in painful physical symptom is associated with the increased remission rate. We know as a clinician, we want to get the patients have a better quality of life, have the remissions, and also the preventions of relapse of the depression. And when we fail to achieve the remissions in link with the patients of depression, it will be linked to relapse of the patients. So when the patients has no remissions, when we said that we used the Hamilton Depression Rating Scale, and then it was said that if we have very little chance to get remission in patients with depressions and also linked to relapse. The problem is in our clinical practice, I am a psychiatrist. When we diagnose these patients with depressions, we use DSM-5 or maybe ICD-10. The problem is our standard diagnosis criteria does not stress and focus on physical symptoms of depression. We see the DSM criteria for major depressive disorders. The problems related to the somatics only loss of energy or fatigue, worthlessness or guilt. It is a very emotional problem, change in weight and appetite, and also maybe kind of like a insomnia or difficulty in sleeping. Dr. Pfaffer said conventional scales for depression used in clinical trials rarely included significant data on somatic symptoms. The inventory that we use very frequent in our clinical practice is a back depression inventory. And if we carefully see this inventory also, there's only 4 related to the somatic symptoms of depressions. It is a loss of energy, changes in sleeping pattern, changes in appetite, and tiredness or fatigue. The problem is when we see the physical symptoms of as a predictors of depression, more patients with physical symptoms will have more chance to have a depressive symptoms. So it was said in the previous study that patients has more than 5 symptoms of pain or physical symptoms will have a chance to get more than 40% of the depressive symptoms or diagnosis as a depression. When we look at the problem with mood disorder and with anxiety disorders, comparisons between the symptom presence and the symptoms absence in the patients with depressions or anxiety, the symptoms of physical symptoms like headache, chest pain, abdominal pain, and also the back pain is rather has a percentage, a high percentage in the patients with mood disorders and anxiety rather in the symptom absence of physical symptoms. We know that sometimes we related depressive symptoms and anxiety problems and somatic symptoms with the diagnosis of somatoform disorder, or in DSM-5 we know as a somatic symptoms disorder. And it was said that at least a third of patients with somatoform disorders have comorbid anxiety or depressive disorders. So come to the mind, I think it will be a great idea to get knowledge and also a good perceptions about what is the specific physical symptoms of the patients with depression and anxiety. So I have a survey. It was done 1 year, and then there were about 11,000 respondents who joined the survey. They had been diagnosed as depressions or anxiety disorder. It was an internet-based survey using surveymonkey.com, and most of the respondents, 57% are women and 42% were men. We used Bradford Somatic Inventory to define specific somatic complaints. It's a very rare inventory that we use in clinical practice because it only, get the specific symptoms. There are 46 questions related to physical symptoms, only physical symptoms in depression and anxiety. We know that the BSI was first published on the article in the British Journal of Psychiatry in April 1991 by David Bartwell Mumford from University of Bristol. I'm sorry if you cannot see this inventory clearly, but you can get it in internet. It's free to download, or maybe you can contact Dr. David to come to this Bradford Somatic Inventory. So from the survey that we conducted, there is a top 10 somatic complaints about the depression and anxiety patients, and they complain about these specific 10 somatic complaints. The first, the most somatic complaints that the patients say it was palpitations, lack of energy, and pain. The other is aches in the abdomen, feeling giddy, feeling tired, excessive wind or belching, hearing buzzing noise in ears, time like a tinnitus-like syndrome, trembling or shaking, and mouth or throat felt dry. From the specific of this graphic, we know that it's very common to see the patients with somatic complaints. It's a depressions and anxiety patients, but also complain so many things about somatic complaints. They complain about more than 10 somatic complaints when they diagnose as depressions and or anxiety. So the discussions of this survey is our results similar with previous study about the relation